Policy Innovation.
Oh, and
Director
Dr. Friedman, sorry, before we start, I just want to let everyone know that it's being recorded too. I think we had a few people join.
Okay.
So, okay.
Dr. Bo Kilmer is the Macaulay Chair in Drug Policy Innovation, Director of the RAND Drug Policy Research Center, and a Senior Policy Researcher at the RAND Corporation. His research lies in the intersection of public health and public safety, with special emphasis on crime control, substance abuse, illegal markets, and public policy. Dr. Kilmer's publications have appeared in leading journals such as New England Journal of Medicine and Proceedings of the National Academy of Sciences, and his commentaries have been published in CNN, Los Angeles Times, New York Times, San Francisco Chronicle, USA Today, Wall Street Journal, and others. He has co-authored books on cannabis legalization. His co-authored book on cannabis legalization was published by the Oxford University Press, and his co-authored book on the future of fentanyl and other synthetic opiates was published by RAND. He received his PhD in public policy from Harvard University, his MPP from UC Berkeley, and his BA in international relations from Michigan State University. Dr. Kilmer, can you start bringing up your screen? And I will tell you what the title is. Yeah. His title today is Decriminalizing Personal Possession of Drugs, a brief review of the evidence. And we're going to probably have each panelist talk for 15 to 20 minutes and then have some time in between for 1 or 2 questions, and then have some time at the end for discussion.
Great. Let me get this up. Can you all see the title slide?
Yes.
Well, great. Well, it really is
and
a.
Could you make it screen, a slideshow?
Yep.
Oh, there we go.
Okay, it looks good. It looks good to me. Does
Yes.
it look okay? All right. Well, okay, great. Well, it's really a pleasure to be with all of you today, and it's always an honor to be on a panel with one of your mentors. I started working with Martin Noguchi, over 20 years ago, and he really kind of helped get me into this business. It was also Martin who told me to, hey, get away from your computer, get out of the library, and why don't you come down to the methadone clinic with me and start talking to the people that you want to help. And I'm just forever grateful for all the opportunities Martin has given me and for his continued mentorship. So I'm especially happy to be on this particular panel. But what I want to do for the next 15 minutes or so is kind of give you a brief review of the evidence on decriminalizing possession of drugs. And then at the end, I also want to spend a little bit of time talking about what is now just being implemented in Oregon. But before I get into it, I want to make a clear distinction between the concepts of decriminalization and legalization. Now, these terms often get used interchangeably and ends up creating a lot of confusion. When we talk about decriminalization, we're typically talking about reducing the penalties for possessing small amounts from it being a criminal offense to a non-criminal offense, maybe something more like a traffic ticket. When we talk about decriminalization, we're typically not talking about changing anything with respect to supply. And when we talk about legalization, now that refers to allowing some type of supply as well as possession for adults. And once you start allowing supply, it really kind of changes the dynamics. And we actually have a fair amount of research on decriminalization, not much on legalization, except for what we see happening within the past few years with respect to cannabis legalization here in the US. So I just want to make it very clear that these are two different concepts. And for the purposes of the next 15 minutes, I'm largely going to be talking about just decriminalization. And in fact, a number of US states have decriminalized the possession of cannabis. But I worry about putting too much weight on some of the earlier studies. So the common story is that there were maybe a dozen or so states that did this in the 70s, and then more came on in the 80s and 90s and later. But research by Rosalie Bakula, who's now at USC, typically these studies would, create two categories, the decrim states and the non-decrim states. Well, Rosalie did the work and kind of looked at the laws on the books and found that actually it's really hard to make that distinction, and there's been a lot of misclassification. So that's why, and it's not surprising that the early studies were kind of all over the place here. So I caution anyone from putting too much stock into the early studies on cannabis decriminalization here in the US. However, there's been a new wave of research starting with California. A lot of people thought that California decriminalized in the 70s, but they didn't. They actually didn't decriminalize the possession of cannabis until 2011. And there was one study that got a fair amount of attention suggesting that after that change, that the past month prevalence for high school seniors actually increased from 24 to 29%, which actually, but what got attention was that was a 25 or 25% increase. But some more recent work by Greg Midget and Peter Richter really kind of challenged this finding. They suggest that there could have been other things that could have led to this change. Potentially the discussion California was having about legalization at the time. There was no increase for the 8th and 10th graders, but perhaps more important, there are actually better data sources out there than what was used in this published study that actually suggested that the prevalence rates were already trending upward prior to decriminalization. But that study does get a fair amount of attention in these discussions. So you should be more aware of this new study by Greg Midget and Peter Richter. There's also been a couple other studies that have come out in recent years looking at some of the kind of late adopters, so Massachusetts, Connecticut, Rhode Island, Vermont, and Maryland. And basically they find that decriminalizing possession leads to large decreases in arrests, but there really isn't any evidence of an increase in youth cannabis use. And here they're typically focusing on possession. But one thing you have to keep in mind when we talk about decriminalization is this idea of net widening. And the classic example is what happened in South Australia. So in 1987, South Australia implemented what was called a cannabis expiation notice system. So essentially, if you got caught possessing a small amount, you would just get an on-the-spot fine. But what they found is within 10 years after they implemented this, the number of fines went from about 6,000 to 18,000. And it wasn't necessarily because there was this increase in consumption. And what they found was that that the net widening wasn't related to consumption, but that it reflected a greater ease with which police can process minor cannabis offenses and a shift away from the use of police discretion in giving offenders informal cautions. And so this is something to kind of keep in mind too when we're evaluating decriminalization, is looking at, well, what does this mean for overall police contacts? If it actually makes it easier, whereas before maybe a cop didn't want to process someone because they didn't want them to get a criminal record, well, now all of a sudden, if it's a lot easier for them to just get a fine, it could increase those police contacts. And then if people don't pay the fines, there can be consequences associated with that. So that's just something to keep in mind. And to be honest, there hasn't been much research on this with respect to the cannabis possession decriminalization in the US. But of course, a number of other countries in Europe and Latin America have decriminalized the possession of all drugs, not just cannabis. That said, there hasn't been much rigorous research on most of these changes. When it comes to discussions about decrim, and most of the focus has been on what has happened in Portugal. But the thing to keep in mind is when Portugal implemented their reforms in 2001, which were to be grounded in humanism and pragmatism, it was a lot more than just decriminalization. So yes, if you got caught with the equivalent of 10 days supply or less, it would no longer be a criminal offense. But at the same time, there was also this really large increase on spending on treatment, harm reduction, outreach services. And then they also implemented what were called these Dissuasion Commissions. So essentially, if the police caught you, you then would have to go meet with one of these commissions. And they typically had 2 or 3 people, maybe someone from social services, someone from the health sector, maybe someone, maybe an attorney. And they would then kind of talk to you about your substance use and then make recommendations. I want to make it clear, though, they can make referrals to treatment, but they couldn't force anyone to go. Another thing to keep in mind with respect to Portugal is even before these reforms took place, there was very little legal risk associated with possessing small amounts. Didn't account for many of the people that had been incarcerated. In fact, it was largely an extension of a 1993 law, which was already focused on emphasizing treatment as opposed to punishment. So that's one thing to kind of keep in mind here. So in terms of on the criminal justice aspect, it really didn't make much of a change. But with respect to these dissuasion commissions, I guess it's been 10 years now. The European Monitoring Center on Drugs and Drug Addiction collected the data, and they found that of everyone that was going to these dissuasion commissions, I think it was close to 70% of them were for cannabis. And in most of those cases, the sentence was just suspended. About 15% of the cases involved a referral to treatment, and then another 15% involved a punitive ruling, where that could be a fine, maybe an obligation to go to a drug education class. You could potentially lose a a license. And they'll make recommendations for treatment, but they can't force anyone to go to treatment. And so what happened after this passed? Obviously, the number of people in treatment for substance use disorder increased. There was a large decrease in rates of HIV as well as drug-induced deaths. And in fact, there have been some calculations suggesting that there was almost an 18% reduction in the social costs associated with using drugs in Portugal. But the thing you have to keep in mind here is that, this all happened 2001, 2002. The HIV cases really peaked in Portugal right around 1999, 2000. So it's not entirely clear how much of the decrease we're seeing can be attributed to the changes in policy versus potentially regression to the mean. And another interesting thing that happened after they did this is, although they were just decriminalizing possession, it turns out for those individuals that ended up getting convicted for trafficking or sales, there actually was a reduction in their sanctions. So that wasn't part of the formal reforms, but just something in kind of how this played out in Portugal. In terms of consumption, so Caitlin Hughes and Alex Stevens have done the bulk of the work on this. They found that there may have been an increase in experimentation, but then when they look at Portugal as well as Italy and Spain, they found that the trends, at least for prevalence in the general population as well as youth, they were pretty similar. In fact, there may have actually been a decline in what they define as problematic drug use in Portugal. So there's no real evidence that there was this large increase in consumption. And I know that's something that people are concerned about when we talk about this here in the United States. That said, look, this is definitely an area where we could use some more rigorous analysis with some real credible control groups. I mean, I appreciate the studies. I've looked at some other countries, but they just kind of were looking at trends. So I know if there's anyone out there that's looking for a low-hanging fruit for a research project, just looking at what happened with HIV and AIDS in Portugal and maybe some other comparison countries, I mean, there's some real work to be done to be able to distinguish how much of that was regression to the mean versus how much of that could actually be attributed to these reforms. I don't think it would be hard to do that. And I'm surprised no one's done it yet. But as I said, so Hughes and Stevens have done most of the work on this, and their takeaway is that the reform warrants neither the condemnation of being being seen as a resounding success or a disastrous failure. But the thing you have to keep in mind is this has now been in place in Portugal for almost 20 years. It's survived multiple governments, and there's no real serious efforts to reverse it. So when you go to Portugal, this really isn't much of an issue. I mean, it gets a lot more attention outside of Portugal, but within Portugal, it's not really up for debate anymore. So as I said, I wanted to say a little bit about what happened in Oregon. So as many of you know, last November, the voters passed Measure 110. I think it approved with 59% of the vote. And it's been characterized as decriminalizing the possession of all controlled substances. So not just cannabis, but it does so much more than that. And so this is another thing to keep in mind. It's kind of similar to Portugal in that way. So right now, and so it went into effect actually February 1st, so it's just a couple weeks ago. So if you get caught with a small amount for personal possession, you can either pay up to a fine, which the fine, it's a max of $100, or you can undergo a health assessment. If you do a health assessment, then you don't have to pay the fine. Now, what Measure 110 also did is it created what they're calling addiction recovery centers. And they're going to put 15 of these all over the state. And this is where people will go for their health assessments, but they're also going to provide wraparound services and also referrals to treatment and other services. And so that's an important distinction. They reallocate money from cannabis tax revenues. But what's really interesting about this is essentially they, as part of Measure 110, it creates this new oversight council. And that council is actually really going to determine how this gets implemented and how the funds are allocated. So they're the ones that are going to determine how much money goes to these addiction recovery centers, but then they're also going to determine, well, what grants go to different organizations to provide outreach, to provide harm reduction services. And so there was a lot of criticism, before this passed, because people, were saying, well, we don't know how much money is going to be going to treatment. And it turns out, it didn't specify it in the proposal. It's this new council, which was just selected a few weeks ago, and I think they just had their first meeting, that they're the ones that are really going to be determining how this plays out. And the other thing to keep in mind is if you
What
get
kind of
caught-
people are on this?
Well,
council?
yeah, it was laid out in the measure. So there were a number of people from different sectors. So it kind of laid out 3 people who represent either treatment. I don't know if it was 3 for treatment, but anyways, it kind of laid it out that way. And so I think the thing that was just interesting is there's no one. When I looked at the list and also went back, there's no one representing law enforcement. And I think that was actually a strategic decision made by those that had written the ballot initiative. But yeah, I forget how long their terms last, but this group is going to have quite a bit of power. But the other thing I wanted to say about what passed with Measure 110 is if you got caught possessing more than kind of the typical thresholds for personal use, and you weren't being implicated for selling, typically that would be a felony. Now it's either going to be a misdemeanor or you'll pay like a $6,000 fine. So this is another thing to kind of keep in mind. There are a lot of different parts of this. So especially when people go to evaluate this, it's going to be much more than just decriminalization. And so in terms of outstanding questions, if you look at the initiative, which was, passed in November, went into effect in February, they were supposed to, these addiction recovery centers for the health assessments were supposed to open up in October of this year. But I think people realize that that's just too quick. And plus everything with COVID. And so I don't know if it's, I know the governor was pushing this to be, pushing them to be implemented in 2022. I think I've seen some people talking about maybe pushing it back a year. And so what that means in the meantime is right now, if you get caught by the police and you want to do one of these health referrals, you actually have to do it on the phone. So there actually is a phone number that they'll give you. That's going to lead to another really kind of interesting research project, looking at those that do the referrals on the phone versus those that do the referrals in person. Another big question, as I said, is how are the funds going to be allocated? And as I said, this oversight council will be determining that. But the initiative allocates at least $57 million in the first year to either go to these ARCs or to other services. Now, I don't know how that's going to play out with respect to the fact that they're going to be delaying the ARCs for potentially a year. But maybe that could just be more money going to outreach and harm reduction services. I'm not sure. Another big question is, at the end of the day, what's the net effect going to be on treatment utilization and criminal justice interactions? I mentioned, this issue potentially with net widening before, but in terms of treatment utilization, you can imagine on one hand, there could be a reduction in utilization to the extent that a number of the people that were receiving treatment were there because of criminal justice interactions. So you can imagine that going down. But on the other hand, there's going to be potentially more money going into treatment. These referrals from the ARCs that can lead more people to actually utilize substance use treatment disorder services. But then also, a big question is, well, what about stigma? If this law kind of does reduce stigma and it leads people to be more likely to talk about their issues with substance use or potentially ask for help, one could potentially see an increase there as well. So that's something we're going to be kind of paying close attention to. And also when we talk, as this group knows, when we talk about treatment, we need to make a distinction between what is high quality treatment and low quality treatment. And obviously we want to make sure we're getting people who need treatment into the best treatments available for them. And the other final point I want to say is a big question is, what does this mean for those who are under 21, for minors? And in fact, the initiative didn't say anything about this. And so I've been talking to some of my colleagues up in Oregon who've been kind of closely following this. And it sounds like it's going to be this oversight council is ultimately going to determine what happens for minors. So it'll be interesting to kind of see how that plays out. So final slide, we just don't have a lot of what I would call rigorous evidence to guide our discussions about decriminalizing possession for all drugs in the United States. A lot of people like to talk about Portugal, and I'm glad they are. But I think we need to be very careful about assuming the outcomes we see in Portugal that we'll see the same things here. In Portugal in general, this is in drug policy in general. A lot of these other countries, especially in Europe, they just have stronger safety nets. So there's a lot of other services available for them. So I think we need to be careful there. And similarly, the research that we do have is focused on cannabis. I think we need to be careful about assuming that you're going to see similar consequences when we talk about decriminalizing heroin, when we talk about decriminalizing illegally produced fentanyl. It's not entirely clear how that's going to play out. And this is the final point is, of course, we're going to be paying attention to Oregon. I still think that even before the research results come out, I wouldn't be surprised. I mean, more states are talking about this now. And I wouldn't be surprised if you saw similar ballot initiatives showing up in other states. But just realize it's much more than decriminalization. And so I think paying attention to the money and kind of where that goes is going to be really useful for us to be able to do a real objective evaluation of this. So with that, I will close. I look forward to hearing the other speakers and answering any questions at the end. Thank you.
Great, thank you, Dr. Kilmer. It was very fascinating, interesting. Anyone want to have one or two questions now before we move on to the next speaker?
Well, I have a question, but maybe it's best to save for a broader discussion. But I just was curious if, Bo, you had a comment on Carl Hart's book.
Yeah.
I mean, it's a big topic, but maybe we could just put it out that Carl Hart is a neuroscientist at Columbia who's written several books on neuroscience, on drug use, and he runs a lab where he does behavioral testing of individuals under the influence of different substances. And he's made an argument that use of drugs is should be seen within the range of pursuit of liberty, and making a political argument about the right to use drugs. And what's controversial about this is that he's a neuroscientist, he's an African-American scientist, and he's very well aware of the harmful effects of drugs on communities and communities of color. So I'm not sure, I put that out, and it might be a broader discussion across the panelists, but just there's different currents at work in the dialogue around legalization. And this is a very interesting and provocative one.
Yeah.
He bragged about using heroin daily.
He says he uses it like people have a drink at the end of the day. Yes.
Right.
Yeah. Well, I definitely think this is something we may want to wait to the end, especially after we hear Joe Friedman's presentation. But I haven't read Dr. Hart's book yet. But I will say
it's not letting me.
But I will say that discussion about the pleasures associated with substance use, there just is not a lot out there. And when I was doing some work with Mark Kleiman and John Calkins, looking at cannabis legalization, we tried to review the literature available on the pleasurable effects of using cannabis. And there just isn't as much there compared to what you see with the harms. So I think that is a valid point. But what that means for policy is another question. So yeah, I look forward to getting into that with everyone at the end.
Okay, Martin, do you want to pull up your slides? And I'll introduce him. Dr. Martin Noguchi is the lead professor for assessment, Part A RAND Graduate School of Policy Analysis, and senior behavioral scientist at RAND Corporation, where he previously served as director of the Drug Policy Research Center. He's also a psychologist, public health researcher with expertise in public policy, contingency management, using mobile devices to support addiction treatment, medication assisted treatment, MAT, for opiate use, street outreach to populations at risk for HIV and other transmissible diseases, reducing barriers to care for vulnerable individuals, and ecological factors that impact population health. He has more than 30 years of funding for research as a grants and contracts from NIH, SAMHSA, HRSA, and foundation sources, totaling over $41 million. He's a senior editor for Addiction and on several journal boards. He's an elected member of the American Psychological Association Board of Psychology in the public interest. And he grew up in West Los Angeles, attended Vassar Colleges, and received his MA and PhD in experimental psychology from Boston University before doing a 2-year postdoc fellowship in drugs abuse and behavioral pharmacology at the Behavioral Pharmacology Research Institute at Johns Hopkins University. Thank you, Dr. Noguchi, for joining us. And Dr. Noguchi's talk is entitled, How the Criminalization of Drug Use Continues to Harm Black Communities. Martin, I think you're muted still. Muted.
I am muted. You know,
Here we go.
I thank you, Ted, for your nice introduction, and to Bo also for acknowledging me. I do remember buying Bo his first computer 20 years ago. So when he was a research assistant for our center, so it has been a long working relationship. So I'm going to actually show slides that I showed the last time I talked at Drew. And so I think, Ted, you're going to see some of these as familiar because in so many ways, many things haven't changed. And I just wanted to frame, how did it get so bad? I think if you're a newer investigator, you can see how bad it is now, but you don't have a good sense of how it used to be and how we got here to begin with, because it hasn't always been that that the Black community was specifically targeted in the aggressive manner that that really occurred during the Clinton administration, and a lot of it had to do with the advent of crack cocaine, which I should point out it was the Black community that was the most adamant about needing to do something about drugs in their community, because the violence was out of control. People felt crack users were really taking over entire neighborhoods, and they demanded that the police do something. And so it happened to coincide with sort of Republican campaigns to really get tough on drugs, to have zero tolerance, and a president, Democratic president, who really saw himself as middle of the road and wanted to, I think, in some ways, appease the right. So this presentation kind of shows you a little bit of what ended up happening then. So as you can see, the real war on drugs didn't really start happening until 1986 or so. Until then, the difference between Black and white arrests was noticeable, but it wasn't huge. And around this time is actually when it wasn't actually a declaration of war on drugs by a president. It was actually a declaration of war on drugs by the Speaker of the House, Tip O'Neill. And the reason why he declared war on drugs was because the first round choice of the Boston Celtics allegedly died of crack cocaine overdose, and his constituents demanded he do something about this scourge of crack cocaine in their communities, and so he immediately took that on as his issue. Now,
Lead
this
bias.
is, yes, Len bias, right? I didn't want to get into too many details, but yes. So around, as you can see, around 1987, these lines begin to diverge. The black line is Black Americans, white line, the blue line is whites, and the brownish line is Hispanics. And as you can see, the rate of incarceration wasn't that different in terms of numbers, although if you look at it at a per capita basis, there was a significant difference. This is whites here on a per capita basis, Blacks and Hispanics. And you can see that Blacks are were significantly more likely to be arrested and to be thrown into prison. And over time, these prison sentences got longer and longer. But that's only a very small part of the story in so many ways. So in 1983, about 1 in 1,500 adult Black males and 1 out of 6,900 adult white males entered prison on a drug offense. By 1999, it was about 1 in 130, almost 1% of adult Black males. Almost 1%, and 1 in 1,800 adult white males were entering prison on a drug offense. So you can see that the disproportions became really dramatic. So the same was true for women. This is again, Black women, Hispanics, and whites. And this is for drug offenses in particular. Now, the disparities had to do with crack cocaine primarily. I would say that that was one of the biggest reasons that Blacks were more likely to get a long sentence, is that 2 gram, essentially a few grams, 5 grams of crack was seen as equivalent to 500 grams of powder, resulting in a 5-year mandatory minimum prison sentence and a felonization. This was eventually reduced a little bit in 2010 to 13-1. There have been many efforts to reduce it further. But one thing you should be aware of is 500 grams of powder equals 448 grams of crack. So it's hardly a fair comparison. If you happen to exchange drugs, and by exchange, I mean hand somebody else a joint, in a school zone, or if you happen to have a knife on you or something that they can call a weapon, like even a baseball bat, in what they call enhancement zones, those are school zones, church zones in some cities, then it becomes a felony. Then misdemeanors become a felony, and mostly inner city settings. These affect primarily inner city settings, where, for example, in Birmingham, Alabama, there is no part of Birmingham, Alabama that's not in an enhancement zone. So it gives you a sense of how it affects those living in the urban area versus the suburban areas. For socioeconomic factors, there, of course, is a focus on low-income populations. There's, of course, profiling that you're well aware of. There's the fact that lower income individuals have to purchase more often. They typically also purchase in public about twice as often. So it doesn't account for the differences in arrests and charging, but it is a difference. There are differences in consumption, although not large differences between Blacks and whites. And of course, the 3 strikes law make all of these things even more dramatic in terms of the likelihood then that you're sent to prison for a very, very long time. Now, part of the point that I wanted to make back then is that these arrests and the large impact of locking up so many Black males in the community meant that the impacts were felt primarily by children and families. They impacted the available healthcare benefits, housing availability, and there were many laws that were passed that also, once you were felonized, you no longer had access to higher education quite as easily. It resulted in many deportations, many employment opportunities were lost, political representation was completely lost with loss of vote. And there was, of course, no impact on drug use and recidivism, and that 80% of those sent to prison on a drug offense ended up reoffending. About 1.5 million children under the age of 18 had one or both parents in state and federal prison. Black and Hispanic children are much more likely than white children to have a parent in prison. Other relevant laws include those mandating rapid adoption, parental rights termination, or those that specify imprisonment as grounds for divorce. By rapid adoption, I mean that in many cases, women were trying to hold on to their children, and they might be sent to prison for, say, 6 months. And rapid adoption laws mandated that the children be adopted within 6 months. So many women lost their child while they were in prison or jail, and unable to really have any rights to maintain the relationship with their child. Families were dismantled, and of course, greater economic burden fell to grandparents and to mothers if it was the father that was arrested. Drug felons were permanently barred at the time from TANF, assistance for needy families, although 32 states have modified that ban. In some states, a criminal conviction can be grounds for losing insurance coverage. Now, this might not seem very dramatic in some ways, but it means that you can't start your own business. In many cases, it means that many aspects of life that require insurance coverage were disrupted. So, the One Strike and You're Out legislation of 1996 revised screening and eviction procedures for public housing. Housing authorities were to consider substance abuse when making access and eviction decisions. In 2003, 5% were denied housing, 6% were evicted for drug-related reasons, according to the GAO. This was actually, as you can see, 7 years after the law was put into place. The GAO said that the small numbers, 5% denied housing, 6% evicted, was evidence that the point that I made in my paper was not true. To many who read the paper, including some in Congress who I met while giving talks in different places, said that it actually encouraged them to get involved in looking into these things because to them it was evidence it was true. When the law went into effect, there were very large numbers of evictions and very large numbers of individuals denied housing, so that by 2003, many people knew not to even try to access housing. So it's the fact that you still had a large number being denied housing and eviction, and still being evicted. Many saw as evidence that the law was impacting the Black community. The law encourages consideration of rehab and drug treatment options, but no path is specified. And public safety, while it is the overriding consideration for housing projects, it leaves drug offenders and their families with few housing options. You can't get federal assistance for at least a year with a conviction for drug possession. A conviction for drug sales means that you can't get eligibility for at least 2 years, and this is for education assistance again. Eligibility can be reinstated if students complete a rehab program and pass 2 unannounced drug tests, but there's no mechanism for doing this. And in 2003 to 04, the GAO said it wasn't a big number, only 41,000 applicants were denied loans. Of course, what fights drug abuse better than than anything, of course, is education. The 1996 Illegal Immigration Reform and Immigrant Responsibility Act precluded judicial reviews of INS decisions. Since 1996, the INS has greatly increased the deportation of aggravated felons. Now, what's an aggravated felon? It pretty much is whatever they want it to be, but in general, it's any individual who's been in jail or prison for up to a year, for a year or more. So if you've had a misdemeanor offense, let's say a bar fight or something, and you got locked up for a year, you become an aggravated felon, and you are then the ICE can deport you if you're not a U.S. citizen. From 1985 to 1995, 300,000 were deported as aggravated felons, and drug-related crimes made up about 30 to 40% of those cases. This is all I know piling on, but I want you to remember all of these things that I'm reading off happen after the person has committed the crime, been sentenced, and left prison. So they've actually done their time, they've paid their debt to society, although we'll talk more about paying debt to society, and then these are the laws that get piled onto them to make certain they never do it again. Earnings potential of non-white collar workers, of course, are harmed for at least a year after felons re-enter communities. Incarceration often occurs during those career building years. Felons are barred from employment in many areas, including the military and government jobs, although the military started a while back, allowing felons to enter the military because they were having difficulty recruiting people. And lack of employment can also mean a lack of healthcare benefits. Political voice, of course, is lost, as about 5.8 million people are ineligible to vote after they leave prison. About a third of those who can't vote are Black. About 13% of all adult Black males in the country were ineligible to vote at one point. And of course, loss of political power translates into a loss of access to services and political voice. Now, they tried to undo this in Florida, as you will recall, just before the last election. But the way that the Republicans responded to this was to say that, yes, you can vote once you leave prison with a felony offense, but you must pay all your fines and the cost of your imprisonment before you're allowed to vote. And then you must go through a process of being certified that you've done this. And of course, so very few people actually were able to demonstrate that they had done this. It's unclear how much crime is averted since we know that incarceration doesn't prevent further drug use. So incarceration by itself is not really the cure for drug abuse. As I said, these policies are all meant to benefit society, but their impacts are disproportionately felt by minority communities, in particular the Black community. And so hundreds of thousands now are returning to society from prison and have been for many years now without really adequate resources to help them to reintegrate. I started this study back in 2000, partly because I was a treatment provider and I had been a treatment provider. And I was always frustrated by the lack of services available and resources available to those in the Black community. And I wanted to know more about these laws that were restricting access to treatment options and to and really building their lives back again. And I wanted to show you this little cartoon that was sent to me by an individual who is prisoner number 95B2625. His name is H.J. Holm. He's pointing out that, yeah, I'm exactly where I'm supposed to be, where society wants me to be. And of course, his alter ego there is George Bush. George Bush had admitted to some indiscretions in his youth, and one ends up in prison for a very long time, and the other becomes president of the United States. So he thought that was he thought I should have this cartoon because he had been reading my work and thought the cartoon was relevant. Now, these are there are a number, not to leave you with a feeling of nothing right is happening, because we've seen large changes and systemic changes that Bo writes about, that many of us write about, that are changing the criminal justice system, that are changing the plight of those who are arrested and who are sent to prison. In particular, the decriminalization efforts and legalization efforts. But I wanted to point out that a few examples that I think are really interesting. The H. W. Hayward Burns Institute, run by James Burns, works with communities to reduce the overrepresentation of youth of color in their juvenile justice system. Around 10 years ago or so, maybe a little bit longer, the juvenile justice system turned from a mostly white system into an almost all minority system. And so the Hayward Institute, or James Burns and his group, began investigating, working with different probation offices to see what they could do, and with juvenile justice systems, to see what they could do to reduce the disproportions. And many of these organizations were under court order to make change, so they were actually willing to pay him to come in and help them. So for example, in San Francisco, monitoring of placement failure rates indicated that Black females were dropping out of a group home at a much higher rate than other females. So by reviewing the data, they saw that there was a disproportion that didn't make sense. An on-site review yielded reports from staff and residents that the reason for dropout was hair. At entry, all residents received a bottle of Prel and they're told to go wash their hair. Now, this is the face of Prel there on the left, and this is the face of those who said, I don't use Prel on the right. So what would happen, the individuals who refused to use the Prel were immediately violated and sent back to the juvenile hall. All adolescents and I'm sorry, actually can't even see, also in San Francisco, they do a risk screening. And all adolescents are brought to juvenile hall, get this risk screen. So they looked at the risk screen and they found that Blacks were assigned to detention at a disparate rate, and it overrides recommendation for detention, even though the score didn't merit it, were greater than 30% for Blacks. So they audited the risk forms. And this, by the way, many of the people filling out the risk forms were members of the African American community who worked for juvenile justice system. An audit of the risk forms found that 14% of the forms were never filled out, 14% provided no reason for referral to detention, and 12% recommended detention because they couldn't find the parent. And of course, many of these parents are working, and at the time, cell phones were not quite as common. So, in fact, they were not common. So, they just said, well, I couldn't find their parents, was something that happened primarily with the minority youth. So they
Martin, about 3 or 4 minutes.
yeah, I
Thank you.
just saw I had my timer here.
Okay,
So data reviews indicate that a majority of the kids referred by override were released after a judicial hearing, meaning they really had no reason for being there, and the judge would berate the individuals bringing them in. So supervisors now have to approve all overrides, and this disparity has gone away. In Santa Cruz, they found that morning sessions in North County had a much higher failure rate to appear for minorities versus white juvenile offenders. And that was primarily because the minorities were housed mostly in South County, and the court was in North County, and the bus service didn't start until court had already started. So they had to get off the bus, run as fast as they could, and get up to the courthouse. And by then they'd been violated and sent to detention. So they asked the judge if she would start later, and she said, no, I have childcare that would just be disrupted. So they built her a new courthouse, a new courtroom in Watsonville. In San Jose and Seattle, the police were just dropping people off that they picked up on the street, young juveniles from minority communities at the detention facility at juvenile hall, without really stating a reason. They just said, well, we picked them up on the street, we couldn't find the parents. And what ended up happening is that you had some fairly pissed off kids and parents. So they gave the police a card to direct them. If it's a mental health issue, take them to a mental health facility. If it's another issue, take them to this facility. And if it's then a criminal issue, then bring them to juvenile hall. And that remarkably decreased the numbers. So in the end, places like Santa Cruz, for example, which used the services, saw that their disproportionate index dropped from a high of 7 to 1 to 2.6 to 1. And they have continued to brag about what a fantastic job they've done in decreasing, systematically decreasing the incarceration of young Black men. And just my acknowledgements and a few statements about these disproportions translate to health disparities through a variety of mechanisms, including access to care and health services, as well as employment. Structural factors are not intractable. And if you have transparency in the system and you can actually look at the numbers and pay attention to the small details, you can make significant, meaningful changes. we all need to take responsibility for this. And as you can see here from Rosa Parks, we still have a long way to go on improving race relations in the country. So that's it. Thank you.
Excellent, Martin. Very nice job. Very important talk. We have anyone have a question or two for Martin?
Now, don't be shy.
I'll start off. I can ask one that maybe Linda's going to address also, but is there any evidence about putting drug abuse users in prison as a detriment to future to other people not using drugs, or is there no data on that? I don't know if I phrased that well.
Well, I think that was a bit of what I was pointing out, is that especially if the male of the household is placed in prison, typically in most cultures, the male is the one that's able to raise more, to make more money, to get a job that has healthcare benefits, and to support a family. It's much harder for minority women to find that kind of support system and job. So to begin with, it really destroys opportunities for those families that are related to the individual with a drug problem, or not even a drug problem, but who have been arrested because of drugs. I neglected to say that there's a really interesting book by Alexandra Natapoff, Natapoff, who talks about punishment without crime, where many systems have gone away from arresting, as Bo has talked about, to the system of penalties and fees and fines. And in many jurisdictions, there's also seizure laws and other uses of financial penalties, even if you've not been convicted. It's just if you've been arrested or suspected of criminal activity. Most people don't get their money back, their car back, or whatever's been seized. And many jurisdictions actually support their entire system using these seizure funds. So, we're moving away from the sort of obvious arrests to a system that is a little more subtle, but still results in disempowerment of the Black and Brown communities.
So, but if someone sees that their friend got arrested, would they be less likely to use drugs themselves, or the other way around? If somebody sees there's no penalties for drugs, they said, okay, so I might as well go ahead and use them. Is there any evidence for that?
Well, in a white community, I'd say that that's true. In a community where it's commonplace, certainly having walked the streets in many, many cities and spent a lot of time with drug users on corners and drug sellers, it's part of the culture. They're used to being arrested. It's part of the culture. It doesn't appear to be a detriment. It actually appears to be a badge of honor on some levels.
Really?
So
Wow.
it's hard to say yes to that. When it becomes so commonplace that it becomes a sort of a cultural normality. So in that sense, no, if you stop with these mass arrests and show discretion, then I would guess that yes, it would begin to have impact, because it's an event that is much less certain, and in some ways more fair, in the sense that, well, yeah, if you do this, there's a chance you might be arrested. But so there may be some detriment effect, but given the uncertainty of the actual event occurring, and given the slowness of the penalties to be experienced, behavioral theory says that no, it's not a detriment.
Okay, great. Thank you so much. Very nice talk. We'll move on to Linda Richter. Linda, you want to pull up your slides? Linda Richter, PhD, is the Vice President of Prevention Research and Analysis at Partnership to End Addiction in New York. She conducts research on the nature, scope, predictors, and consequences of substance use and addiction, especially young people. She leverages this research to help awareness among parents, educators, health professionals, and policymakers about addiction science and best practices in substance use prevention and addiction care. Dr. Richter received her doctorate in social psychology from the University of Maryland. We're very happy to have Dr. Richter on our panel today. Please go ahead.
Yes, thank you so much for having me. So I'm going to talk about special considerations for preventing youth drug use in the context of drug law liberalization kind of broadly. So talk both about decriminalization and also legalization. So first, in terms of drug decriminalization, I'm going to try not to be too repetitive with the prior speakers. But generally what the existing research shows, which there isn't that much, as was made clear earlier, is that it's a sound policy, but only if it's implemented within a larger public health framework. So as was made very clear by the prior speaker, thank you, is that decriminalization as it relates to the war on drugs. So the war on drugs has no place in our society, and that if we're going to fight a war, it should be against stigma and ineffective care and not against the people who use drugs or have addiction. But decriminalization alone without a well-resourced public health infrastructure will not prevent or treat addiction, and on its own, without those protections, can actually harm those who we really seek to help through policies like decriminalization. So what does a public health approach do? It generally, when you talk about any kind of disease, it aims to reduce the number of people who have an illness or a disease or a condition, reduce the severity, and prevent new cases. So it relies on a healthcare rather than a criminal justice infrastructure. It provides incentives and support instead of punishment to promote health. And it employs interventions that are based in science and not fear and discrimination. So within the public health framework, it encourages more people to get treatment, as it helps remove two of the key barriers that people have for seeking treatment, which is a fear of arrest and also stigma or social marginalization. It discourages drug use through providing resources for prevention, reducing demand, and weakening the criminal market. And it increases access to interventions that are prohibited or limited by criminalization, harm reduction approaches such as syringe exchange or safe consumption sites. And it helps free up resources that would have been used for law enforcement or incarceration to be allocated toward prevention and treatment. And finally, it helps reduce the pervasive and damaging stigma of addiction. But it's important to note that decriminalization does not equal legalization, as Dr. Kilmer pointed out earlier. When you have decriminalization without legalization, as was mentioned before, personal use of small amounts of drugs can be decriminalized without being legalized. It's the case now in Oregon and has been since 2001 in Portugal. It's about to be in Washington State and also in Norway. And I won't review again the data on Portugal because that was covered earlier, but it was just a good, we think a good example of embedding decriminalization within a strong public health framework. Again, we're not sure of all the details and certainly not how it would apply necessarily in the US, but there is some indication of positive results, and that was achieved without legalizing drugs. So again, this is my little balance of the pros and cons, but again, this is covered earlier of what occurred in Portugal, which it encouraged treatment, reduced infections, overdose deaths, and problem drug use. Again, how much that is directly attributable to the decriminalization, we're not 100% sure. But generally, the kind of negative side of decriminalization, even within a public health framework, is that it can reduce the perceived risk or harm of substance use, and it does not necessarily eliminate the criminal market. When you talk about legalization, though, there are some positives. One is that it allows the drugs to be regulated, which presumably will increase their safety. And it allows drugs to be taxed, which can generate revenue. But some of the cons, which I'm going to go into a little more detail in a minute, especially as they relate to young people, is that it creates a strong profit motive for the industries that sell the substances. and they profit the most from heavy users and also young users. It encourages aggressive marketing and advertising to these vulnerable groups. We know that the tax revenue that is raised does not necessarily cover the costly consequences. And we know that the money is rarely applied to a sufficient extent to prevention and treatment. So when you talk about legalization when it comes to drugs, you're really talking about commercialization, which means that the industries that have an interest in these markets advertise and market aggressively, which leads to increased exposure, availability, and access to the drugs, which can increase normalization of drug use, reducing perceptions of risk and harm, which can lead to increased use. And obviously that leads to increased incidence of addiction, morbidity, mortality, and a whole range of costs. So I really just want to focus primarily on young people when I talk about the issue of legalization. Again, I know some of the panelists were focused specifically on decriminalization. And again, when it comes to young people, really the concern from my perspective is on legalizing substances rather than decriminalizing them. And what's really important to do when you talk about legalization is to look to the past and to look at substances, addictive substances that are currently legal, nicotine, alcohol, some controlled prescription drugs, obviously, and marijuana in certain states, which are the most widely misused substances among young people. And they're the primary or contributing cause of thousands of preventable illnesses and deaths each year. And just the kind of logical reason is because when they're legalized, it promotes commercialization, does not guarantee adequate public health protections, regulations, or that health-based interests will be prioritized over the industry's financial interests. So I just want to show some data that kind of illustrates this. These are, the next few slides come from different data sources, but I'm just would like to just contrast illegal substances with those that currently remain illegal and how they apply particularly to adolescents. So these are national data on rates of past year initiation of substance use among adolescents, and this is from the National Survey on Drug Use and Health from 2019. So cigarettes, they don't measure vaping, nicotine vaping, unfortunately, in this data set, or haven't yet started to do so. So cigarette rates are obviously low at this point among youth, but we can clearly see that alcohol and marijuana initiation, which means first use, are much higher than rates of first use of a illegal drug like cocaine. Here, what you're looking at is a comparison of past year initiation of cannabis or marijuana use among adolescents. So the national average is about 5.7%. Again, this is based on the national data from the National Survey on Drug Use and Health over the course of 2 years from 2018 to 2019. And just to compare it with some of the states that have legalized marijuana, recreational marijuana, by the year 2018. And what you could see is that in all the states that have legalized recreational marijuana, the past year initiation rates among young people is higher than the national average. This is from a different data source, also a national survey of young people from the Monitoring the Future study, which shows here rates of past year use. So the prior slide was about first use. This is just past year use in general among adolescents. And again, you see nicotine vaping, alcohol, and marijuana, which are more legal substances, rates are significantly higher than other illicit drugs. So this slide comes from a survey that my organization did a year or two ago with teenagers ages 12 to 17, looking at how easy they think it is to access each of a range of substances within the course of 1 hour. And again, you could just see that when it comes to nicotine, alcohol, marijuana, well, nicotine and alcohol especially, the perceived ease of access is far higher than it is for illegal drugs. Likewise, also from the same survey, we asked, how worried would you be if you learned that a friend of yours used each of these, a whole range of substances actually, once or twice? And again, what you could see is much higher concern or worry for a friend who uses cocaine or heroin, which were the illegal drugs that we measured at the time, compared to what are currently legal substances. Obviously, marijuana depends on the state. So we know from tons of research that among youth, perceptions of risk is a really important factor when you consider an individual adolescent's likelihood of engaging in drug use or substance use. So if you want to talk about marijuana or cannabis legalization in particular, when you're considering the effects on young people, as I showed earlier, in all states that have legalized recreational marijuana, rates of first use among adolescents are higher relative to the national average of initiation in this age group. Now, it's important to consider the context here. We don't know that this is causal, obviously. It could be that in states where rates of use are higher already, they are more prone to or more inclined to legalize the drug. So the direction of the relationship and the nature of the relationship is uncertain, but it's a pretty consistent finding. A study that just came out, I think it was a week or two ago in California, examined the effects of recreational marijuana legalization that occurred in California in 2016, and found that it was associated with increases in lifetime odds and past 30-day marijuana use among adolescents. And what was pretty concerning here was that they found the association to be much stronger among younger kids than older, and among females versus males. And younger teens and females historically have been considered the lower risk groups when it comes to drug use. So again, it's not possible to draw conclusions here, but what it might be suggesting is that when drug use becomes legalized, it becomes more normalized, and then use starts trickling into the groups that otherwise may not have engaged in substance use. Another recent study that looked long-term at people ages 10 to 20 found that they were about 7 times more likely to report marijuana use and about 3 times more likely to report alcohol use following cannabis legalization in their state. And that was even controlling for other relevant factors. A study that we conducted examining national survey data found that teens who use marijuana are at least twice as likely as adults who do so to become addicted to the drug. So this is not a study of legalization, but it's a study of why we care so much about potentially increasing the number of young people who use drugs, because the risk of addiction is so much higher among if a young person uses a drug compared to an adult. And again, I won't go into it, but that's because of the brain development issue and all the other factors that go into development during adolescence that make young people so much more vulnerable to the effects of drugs. And again, examining the effects of marijuana use on a young person, there's a lot of conflicting research out there and a lot of uncertainty, but certain things have come through in terms of their strength of the evidence. So there is a heightened risk of addiction and an increased risk of other substance use. And we also know that there's an increased risk of certain cognitive deficits and mental health problems, specifically certain psychotic disorders or symptoms, especially among those who use heavily and regularly. Just back to the issue about use as it relates to a substance use disorder. An analysis of data from the National Survey on Drug Use and Health, we found that, and others have found the same thing, that earlier a young person starts using, the higher the likelihood of developing a substance use disorder. So here we have age of first use of marijuana against the percentage who meet criteria for a marijuana use disorder. And you can really see that obviously the younger a person is when they first use, how much higher their risk of addiction is. and almost an exact same pattern when we looked at the same, when we conducted the same analysis looking at alcohol. So just to talk a little bit about why this happens. So once a drug is legal, we know that the economic interests of the industry that sells it dominate the public health restrictions. So if you look at tons of research on nicotine, alcohol, and marijuana in states where it is legal, it shows that there are increased perceptions of safety among young people, and it normalizes use among youth. It increases exposure through retail outlets in the community, advertising and marketing, which increases access in the homes and schools and neighborhoods, and that relates to increased use. Industries are emboldened to prioritize their profits over health, and their goal is to target young people and heavy users because that's where they get the most long-term profits from. Because if you can kind of attract a young person to your product, you develop brand loyalty, they develop brand loyalty, and then you are more guaranteed to have that person as a customer for a long time, especially if your product is highly addictive. And obviously heavy users also in numerous studies have been shown to account for a significant proportion of the profits when you talk about the tobacco industry, the alcohol industry. Obviously, we know when it came to the rise of nicotine vaping in this country a few years ago, there's just a ton of evidence that the same thing was happening as what happened with the tobacco industry years ago when it came to cigarettes, and that continues to happen with the alcohol industry and the pharmaceutical industry, which is you have well-funded lobbyists who are happy and heavy political donations that really kind of restrict the amount of regulations that these products are put under. There's aggressive marketing to youth and especially to disadvantaged communities and to minority communities. And there's significant health, financial, and social costs associated with this. And there are government regulations when a drug is legalized, but they just have no chance against the influence of these industries when it comes to actually putting through regulations or restrictions that actually protect young people from drug use and addiction. So just a couple of summarizing or concluding thoughts. Again, as was mentioned repeatedly, it's important to distinguish between legalization and decriminalization. If you have decriminalization coupled with smart policies, effective prevention and treatment, it can address many of the concerns around racial inequities that are, bringing about the call for more liberalization when it comes to drug laws, without creating a profit incentive that ultimately harms those communities and the larger public health. It's really important to proceed with caution and base these kind of decisions and reforms on data, with special attention to the effects of these laws on youth and other vulnerable populations. These laws will backfire if they're not introduced in the context of well-funded, research-based public health frameworks. Just as an example, we deinstitutionalized mental health treatment in this country a few decades ago, and it ended up, creating, obviously it was good for many reasons, but, the effects were homelessness, inadequate mental health care, and a whole range of problems. So when these things happen without, the support and resources of a good public health framework, we really are introducing a lot of problems into the system rather than solutions. One argument that's often used in favor of legalization are the financial benefits from the taxes that are raised, but we know from the tobacco settlement and from nicotine and from alcohol that the taxes rarely pay off when it comes to public health, because typically, even though it's promised, the new funds rarely are applied to prevention and treatment of substance use disorders. And the amount that's raised rarely meets the increased need for prevention and treatment funding that arises from legalization. Finally, I'll just mention COVID. We know that we're in the midst of a massive and growing mental health crisis due to COVID and increases in substance use, which we are ill-equipped to deal with. Adding more drugs into the mix will heighten the risk of creating more young, long-term users, and will also increase the number of heavy users of these drugs. So just quickly, some recommendations for us to think about for policymakers and scientists is that we should reimagine drug policy in this country, but we should be careful to base the decisions on science and not public pressure and not business interests. It's really important to carefully consider how policies and regulations will affect youth, both in the short and long term. We should carefully look to states and jurisdictions that have liberalized drug laws and learn from their experiences. We certainly need to fix current disparities in enforcement and ensure racial equity in future policies and enforcement, but we shouldn't do that while compromising the health of communities of color, youth, or other vulnerable populations. And again, just prioritize the protection of children, adolescents, and young adults who experience lasting adverse effects from exposure to addictive substances. So thank you very much. Let me stop sharing.
Great talk, Dr. Richter. Really, really
Yeah.
excellent summary. Thank you so much. Anyone questions for Dr. Richter?
I just have one comment, which is that I really appreciated your use of the public health framework. And I think it's been really interesting during COVID that there's been so much discussion about public health and what it means, and that it's created a dialogue where, because we're also riveted on COVID, that the issue of the public health approach and then also the discussion why we've had a degraded public health infrastructure over the past several decades, because we haven't prioritized public health. And as I've been hearing that discussion, I've been kind of hoping that the public is becoming more amenable to that concept, because for so long our drug policy has been dominated by the criminalization, as you and the other speakers pointed out, so that I'm hoping that we'll have an ascendancy of public health understanding, but perhaps later we can discuss some of the barriers to the public's acceptance of a public health framework, because I think there's some unique aspects in our culture that make it kind of less compatible with our cultural perspectives, and particularly when applied to drug use. So I don't know if that's a question, but I just wanted to say I really appreciate it. And I think this issue of the public health framework is so critically important.
Yeah, I think it's a great point. This is kind of a slightly off topic, but with COVID, it kind of made me think of the parallels actually to substance use when it comes to young people. How it took, obviously this doesn't apply to the whole country and there's tons of division, but it took very little time for schools, families, health professionals to kind of get their act together and get the public health message out there when it came to protecting kids from COVID, and teaching kids what they need to do, enforcing it. Parents weren't wishy-washy about it for the most part. You have to wear your mask, you cannot be near people, etc. So, I think there's a lot to learn there about empowering families and communities that you can actually take a public health approach with an issue that is a public health threat to young people and apply some of those same lessons to how we address substance use among young people as well. So it's something to think about.
And following on that, some of the resistance to the public health, I mean, we've had active pockets of resistance to the public health messaging on the basis of individualism.
Right.
So, and I think a lot of our challenges around drug policy in this country is if you use drugs and you get into problems, it's your own fault. It's your own problem. It's something about you. So our extension of individualism and to blame.
Yeah, great point.
Okay, we'll go on to Mr. Friedman. Joseph, you want to pull up your slides? And Joseph Friedman, MPH, is an MD PhD trainee at UCLA, where he is currently completing his PhD in the social medicine track of the Medical Informatics Program with the Center for Social Medicine. He holds a master's degree in public health from the University of Washington, focused on global health matrix. His undergraduate work was ethnographic in nature, and he subsequently completed a 3-year data science fellowship at the Institute for Health Metrics at the University of Washington. His current research focuses on using data science and qualitative methods to assess health disparities and their structural drivers, especially in the context of the North American overdose crisis. He has ongoing research projects related to harm reduction and overdose surveillance. And I did see Joseph's op-ed article in the Los Angeles Times, which I congratulate him on. And that's how I reached out to him. Mr. Friedman, thank you very much. Please go ahead and start. And his talk today is entitled Ending the War on People Who Use Drugs, the Case for Legalization.
Great. Thanks so much for having me. Can everyone see the slides and hear me okay?
Yeah.
Fantastic. So I am going to make the case today that prohibition has utterly failed to accomplish any of its aims, at least its publicly stated aims. So I think most importantly, prohibition has not kept us safe. Here's some data from a paper in Science a couple of years ago where they showed that here on the right-hand side, you can see overdose mortality per 100,000 people. And from 1980 through 2016, it has been increasing exponentially. And as I think we all know, unfortunately, through 2020 has gotten substantially worse. On the left-hand side, you can see the particular drugs that are associated with overdose mortalities over the past 20 years. And while the drugs themselves have changed, there's been a constant march in our country towards higher and higher rates of overdose. And this is, of course, despite prohibition and escalating punishment and all of the things that my colleagues have been presenting on for the past hour and a half. Importantly, prohibition does not stop people from using drugs. This is not a value judgment. I'm definitely not here to say that drug use is good. I'm simply saying it is an empirical observation that addiction is part of the human condition. It is part of human nature. We can never end addiction. It's simply something that has always been, and I think unfortunately always will be. So the question is, how can we minimize the harms from addiction? So here's an interesting data point, I think, from the prohibition of alcohol. So you can see that this is from 1910 until 1930, and alcohol was outlawed, the sale and trafficking of alcohol was outlawed in 1920. So for the 10 years leading up to the prohibition of alcohol, there actually was a decrease in the consumption, the per capita consumption of alcohol, as a number of cities and municipalities outlawed it, right? And then there's this federal ban, and all of a sudden you can see this very low bar in 1920 where alcohol consumption went way down. But then over the next 13 years, alcohol is still outlawed and consumption started to go back up because the prohibition markets sort of rose up to fill the void. There's demand for a product, and as we know happens, the illicit markets sprung up to fill the void, and consumption went back up to, estimates vary, but something like 65 to 80% of the alcohol consumption that we saw before the prohibition movement. And so what we see is that consumption went down a little bit, but, and this is decriminalization, right? This isn't, it wasn't illegal to possess alcohol for the drinker. It was just illegal to sell alcohol, very similar to what Oregon has just passed. And we see that consumption went down a little bit, but the harms from consumption skyrocketed. And I'm going to make the case that this is exactly what we see with other drugs now. So prohibition markets lead to stronger and more dangerous forms of drugs. And many of you probably know that this is referred to as the iron law of prohibition. And I'm really using the term prohibition market here to make it clear that prohibition is a choice, that the market will be illegal. The market is going to exist and we have to choose. Do we want the market to be completely illicit, or do we want the market to be competition, or do we want the market to be everyone purchases it from the government? But there's going to be a market because there's a demand for this product. So getting back to the iron law, here we can see the percent of all expenditures on alcohol that were represented by distilled spirits, right? As opposed to beer or wine, this is hard liquor. And we can see that during Prohibition, as it became much more dangerous and costly to transport alcohol, all of a sudden, the percentage went from about 40% up to 90% of alcohol being purchased was a much more concentrated form and therefore more dangerous. As I think probably most of us have had this experience at some point in our lives. So the problem is that Prohibition markets also remove quality control. So there's a lot of evidence for this, but I'd like us to all imagine you go to a bar or you buy a bottle of beer and you bring it back to your house and you're going to consume it, but you don't know if this bottle has the equivalent of 1 shot of alcohol or 20 shots of alcohol, and you don't know if it's been poisoned with something that could kill you, right? And the only way to find out is to consume it and see what happens. And this is effectively what happened during alcohol prohibition for many people. And this is what is happening now with opioids, purchasing illicit opioids on the market and not knowing if they're contaminated with, for example, illicitly manufactured fentanyls. So alcohol poisoning during Prohibition spiked because alcohol started to be contaminated with methanol and other toxic alcohols. And all of a sudden, there was this huge increase and there's this new public health crisis of methanol poisoning. Actually, interestingly, there was a methanol poisoning outbreak in Iran during COVID because there was a big increase in demand for alcohol and it's not legal there. And so all of the same problems could be seen. And today we can see with illicitly manufactured fentanyls, they're actually overwhelmingly driving the overdose crisis. Here's some data from LA County, where you can see, this is actually through the second quarter of 2020. So you can see there's been a huge spike over the past 5 years in fentanyl-related overdose deaths, and a particularly large increase in the last 6 months of the data corresponding to the beginning of the pandemic. So what we can see here is that fentanyl overdoses specifically in the past 5 years have essentially doubled the overdose death rate in LA County. And in some sense, you know, we're sort of powerless to prevent fentanyl being added to the opioid supply. Another important point is that Prohibition markets, by definition, necessitate violence. So I'm going to share an excerpt here from an ethnographic study that I participated in. And this is from Philadelphia. And basically in this paper, we charted the lives of a number of young men who were from first and second generation Puerto Rican families, immigrant families. Their parents and grandparents came to Philadelphia to work in these factories. Like this is one example in the picture in the background. The factories closed because of deindustrialization, and the informal narcotics economy sort of rose up to fill this void. And for the young men whose lives we documented in this work, it was really the only conceivable way to find meaningful employment. And it was in many ways the only kind of employment that there was any sort of role model for. The only sort of example of a successful male was working in the narcotics economy. And so it reads, in our field site, the sale of cocaine and heroin represents an extremely lucrative market located in a deeply impoverished area. In a single day, hundreds of thousands of dollars of untraceable cash routinely flow through a neighborhood where the majority of residents live well below the poverty line. In this context, Tito and Leo, the two young men we're talking about here, needed to be able to perform violence at a moment's notice to protect their reputations and maintain monopoly control of profits. In a clandestine market, there is no legal recourse should product or profit be stolen by an employee or competitor. Order, therefore, generally is maintained with violence or the threat of violence. And I will say that, unfortunately, in the cohort of young men who this article is written about, essentially all of them either ended up killed or hurting someone else and ending up in prison. So that's violence on a micro scale stemming from prohibition markets. But of course, we know that this happens at a macro scale too. Here I'm showing deaths per 100,000 due to violence in the United States in dark blue, and in Mexico in light blue. And of course, the United States has much higher violence rates than many wealthy countries, and Mexico has significantly higher death rates. And you can see this very large spike in the last 15 years stemming directly from the war on drugs, jointly sort of coordinated by the US and Mexican government, assassinating drug kingpins, creating power vacuums, leading to a truly massive civilian sort of innocent bystander death toll. And I can say, from living in Mexico for several years myself and having Mexican friends and loved ones, that everybody knows at least one family member, friend, someone who's been killed because of this violence. And it's all of the fighting is over a piece of the pie that is the US drug consumption demand. And it's, you know, the estimates vary from 80,000 to 200,000 people who've been killed in you know, less than 10 years. And it's truly like an astounding level of violence. And all of it would, in many ways, is directly tied to American drug, you know, just filling the demand for drug use from Americans. And I would argue this is also true in many other countries in Latin America, and something we need to really weigh on the scales in terms of legalization versus decriminalization, because decriminalization doesn't do anything about this. I think it's also important to recognize that the targets of prohibition are political, not sort of empirical, and they stem from political histories. So this is a great study in The Lancet a number of years ago, looking at the harms caused by a number of drugs in the UK. And they concluded that, in fact, the most harmful drug is alcohol. And alcohol and tobacco are in many ways much more harmful than other drugs, which are highly punished and illegal to use or sell in the United States. And so there's a sort of disconnect between the actual harms associated with each drug and the punishment associated with using it. So why do we have prohibition then? And I would argue that prohibition, if you go back to the history, is really linked to racism and has always been a tool of racial oppression, as I think was demonstrated very elegantly by some of my colleagues earlier today. Here's a quote, which I suspect many of you have heard. This is from John Ehrlichman, who was a domestic policy advisor to Richard Nixon, who reportedly said in an interview many years ago, the Nixon White House had two enemies, the anti-war left and Black people. We knew we couldn't make it illegal to be either against the war or Black, but by getting the public to associate the hippies with marijuana and Blacks with heroin, and then criminalizing both heavily, we could disrupt those communities. We could arrest their leaders, raid their homes, break up their meetings, and vilify them night after night on the evening news. Did we know we were lying about the drugs? Of course we did. So it's a little bit contested if this is actually what Nixon believed. We know he was a racist, but I think if you actually look at the data, it's very clear that this vision of the effect of prohibition and the war on drugs has absolutely come to fruition. And I won't talk about that anymore because it was, I think, beautifully covered earlier today. So I'd like to make a point that prohibition markets and medicalized markets often provide the same drugs, the same molecules to different people in our society, but with massively different stakes. So this is some data from a paper that I published a couple of years ago in JAMA Internal Medicine. It's looking at California, and it's looking at the percent of the population that receives in each year a number of controlled substances. So as these are the sort of gradients each represent all of California, as you move up through the y-axis, you're moving through whiter and whiter zip codes in California. And as you move from left to right, you're moving through higher and higher income zip codes in California. And what you can see here is that for both opioids and benzodiazepines, whiter communities receive about 300%, it's 300% more likely that an individual in the widest quintile of zip codes in California will receive an opioid or a benzodiazepine than in a community of color, right? And so what we're seeing is that one group of people is receiving the same molecules, much more likely to receive them regardless of the sort of underlying condition that they're being treated for. There's a really fantastic book that just came out by David Herzberg, where he charts the sort of racialized history of access to medications through the healthcare system and through prohibition markets that I would highly recommend. So I like to sort of think of the responses to drug use as existing on a spectrum. And, we've seen sort of a lot of cases for different points on the spectrum today. And I think we should have a healthy debate somewhere between decriminalization and legalization, I think would be very positive. So again, this point has been made very well today, but everything that is being discussed that is not legalization is decriminalization or worse, right? And so what we've seen in Oregon, what we saw with US alcohol prohibition, I would put somewhere around here as decriminalization, but really without the sort of very comprehensive universal healthcare and social services that we have in a place like Portugal. And I think it's just important to say that decriminalization leaves the entire sort of apparatus of illicit markets and everything that comes along with that completely intact. So in the interest of time, I'm going to skip over a couple slides that I had prepared because I think these things have been covered well in terms of some harm reduction benefits and some things that we should cover, though I'm happy to talk about that if anyone is interested. That's really what a lot of the op-ed that I wrote that was referenced to was about, and just sort of talk about here. So, this is a sort of similar graphic to my colleague's graphic in the last presentation, although the scales are tipped in the other way because my view of the evidence is a little bit different. So on the harm reduction side of things, we can replace illicit opioids with Suboxone, with methadone, with even heroin that's prescribed and safe and produced in a factory and known to be free of fentanyl. We can provide drug checking services and overdose prevention sites, and these things will reduce the acute risk of overdose. I think they will also minimize the social and economic harms of addiction, but drugs will still be sold on prohibition markets. We will still have massively powerful cartels running Central America and sort of outcompeting the Mexican government for control of the country, and massive amounts of violence, unnecessary violence and death in many cities in the United States. On the other hand, if we legalize and regulate drugs, we have the opportunity to completely defund these criminal groups, take all of that money and invest it in things like treatment. I think we can reduce violence. Consumers, well, it's really the only way that consumers can actually have accurate information about the products they're consuming, that they are going to consume regardless of the law. It's just a matter of how much. And of course, there's a huge sort of economic incentive, both in terms of the tax revenue, but also just in terms of not fighting the war on drugs, not having to take on the cartels and pay for mass incarceration, even of people who sell, right? Which is still a huge burden of people who are currently incarcerated. So with that, I'll finish. And I have added a few books here that I personally have found very insightful. And I'm adding my Twitter and email, and I'd be happy to take any questions. Thank you.
Thank you so much, Joseph. It was very interesting. Questions from the trainees, especially in the audience?
Yes, I have a quick question. I was trying to type it into the chat, Joseph, but as we think about the model of legalization, wouldn't cartels just adapt to these markets? So I'm just thinking around cannabis and some of the, I don't want to call it dark money, but illegal money that has been, funded into some of these cannabis licenses. So, I mean, is that really what would happen? Are we just speculating that, we could kind of dismantle cartels as a result? To me, it seems as though cartels would just shift into the legal market space and marketplace and and just adjust tactics. I would really love to hear more kind of, because that's my big worry with full scale legalization.
Well, if cartels want to take their money and put it into legal markets, I would actually argue that that's a great outcome, right? Because like in Mexico, cartels are buying tanks, and I mean, like they have armies, right? It's massively expensive, truly incredible level of militarization that they just could not afford without drug money. Yes, there are other kinds of crime, and that's a problem, and like that's not really what we're talking about today. But I would just argue that all of this money that's currently existing in illegal markets, like it actually would be doing a lot more good in legal markets. And if it's moved into, like, for example, if it's moved into legal marijuana, sure, we can argue about is it good or bad, where this money came from. But the reality is it's not producing tainted products. The government has a lot of control. And I think that's a key point that, I really appreciated in the last talk, is that regulation is key, right? I mean, in fact, like completely free market capitalism for drugs would be extremely irresponsible. And I would argue that prohibition basically produces all of the harms of free market capitalism. Plus there's like the sort of extra harms of incarceration, but in either extreme, the government has no control about what people are consuming.
Other questions, audience members? Please go ahead and ask. If any of the panelists want to respond to some of the other panelists, also we can do that.
Right. I mean, so sorry, just to answer the question in the chat, I would actually like, terrorism is this kind of like political word, right? Like what's a terrorist and what's not. But like the cartels in Latin America are absolutely terrorists. I mean, like
I'm going with non-state actors. That's what I'm going with. I'm also a political scientist, so that's why I'm kind of going into
but exactly. I mean,
I'm going
like
with non-state actors.
So I don't know how much you followed, what's happened in Mexico, but like last year, they captured this cartel kingpin, and the cartel basically just started just like going around. Yeah, right. And like this is a non-state actor.
Yeah.
Who I would love to defund, because they don't need all of this money. I mean, it's massively damaging.
I would really be curious to hear from other folks, what their thoughts would be, because this is such a provocative conversation. I love it.
Yeah, really good.
Well, if you think that you can keep the cartel money out of this, I think that's highly unlikely. I think in the history of drugs in America, you see with the speakeasies and the end of prohibition, with with any number of substances that have been more liberalized, that it's really those who were in place, who were able to produce, and who have a lot of political influence and a lot of money, that they're able to capitalize on their position as prior providers, right? So, I think that's something that in some ways you want to worry less about, and more about the fact that you're going to be collecting taxes from them. You're going to be placing restrictions on what they can and can't do, that they become more formalized and therefore more subject to rules and regulations, and that you have less of an incentive for violence and for creating these large scale illegal drug chains throughout the world that end up corrupting governments and corrupting systems. So I think in many ways it still gets at harm reduction, right? I know, Bo, you walked in Colombia, and you're muted.
Thanks. It's interesting. Couple months, or maybe more than a couple months ago, a politician in Colombia argued that that the Colombian government should just buy all of the cocaine from those who are producing it. Which, when you first hear that, you think, well, that might make sense. But then when you realize that most of the money, it doesn't cost a lot of money to get the kilos, and to buy it in Colombia. Those that they're in the trade, a lot of the Mexican drug trafficking organizations, they would just pay for more. They would pay more than whatever the government would pay for. And so, but when I think about, this is moving away from legalization a little bit on one hand, but then also when I think about alcohol, and look, I don't think we do a very good job of regulating alcohol in the country. I think Joe, you're right. I'm absolutely right. We know what we're getting. That there's no debate about that. But in terms of the power of the industry and kind of how we deal with it, and just how cheap it is, it just causes a lot of problems. But one of the things I've been doing is I've been doing some research on a couple programs in the Dakotas where essentially you're losing your life, where they've implemented you're losing your license to drink. With this idea being that when you turn 21 in the United States, you pretty much get the ability to consume and purchase as much alcohol as you want. But at what point should we potentially suspend or lose this, or kind of revoke this license? And what they've been doing there is essentially for those individuals whose alcohol use is leading them to repeatedly threaten public health and public safety, essentially they get arrested, they're ordered to abstain. And then they're also subject to frequent testing, sometimes twice a day. And if they test positive for alcohol, then they'll go to jail for a night or two. But it's interesting, there's no treatment component of this whatsoever. And it seems to be making a big difference in terms of public health and public safety outcomes there. And I've often thought about that in terms of, that particular model, and whether or not it has to be incarceration is another story, but that's actually not incompatible with decriminalization. Right? You could actually have a situation where you could decriminalize, or in fact, you could potentially legalize possession, to where, if you get caught, to where it wouldn't be an offense. However, once your use leads you to repeatedly threaten public health and public safety, that's when you could potentially revoke that license. And so I've been doing a lot of research on this in the alcohol space. I've been thinking about it in the context of other substances. In this model, so many of you know about, this is very similar to the HOPE program, and which I think makes more sense for some of the, for the stimulants. I think once you start talking about opioid use, and in terms of incarcerating someone, and then what we know in terms of the risk of arrest afterwards. I think you need to rethink that model for opioids. But it's just, I think that there's some. Definitely, as there's this potential movement toward decriminalization, I think it opens up these questions about, how do we deal with the individuals whose use leads them to repeatedly threaten public health and public safety? And so one option is to put them into treatment, force them into treatment. That's the kind of the drug court model. This other model says you've essentially lost your right to use. If you want treatment, here it is, but you don't have to go. But I also, when thinking about this, it would be, maybe this is idealistic, but it sure would be nice to live in a world to where when people wanted treatment, they could actually get it on demand. So I think that's something that we need to be talking about. And I see that as being much more, potentially feasible than legalization. I'm really happy that we're having this conversation. It's covering all different areas here. And Joe, I really appreciate you bringing in the international aspect. So I think when people start thinking about doing cost benefit analyses and cost effectiveness analyses, so much of it is focused on, the US population. And I think once you kind of expand that to include all humans and not just those in the United States, I think that can lead to very different ratios and kind of very different costs and benefits when you're kind of doing those calculations.
This reminds me, when you talk about treatment on demand, that there was a Republican congressman who wanted to start up prosecutor courts to try to deter some individuals and to shunt them away from the criminal justice system. and the Democrats asked me to testify, and I said, but I'm for more treatment options, no matter where you can find them. And they said, yes, but you may have a different spin on this issue. So I started out by talking about our paper, controlling cocaine, and about how, in looking at the cost benefit analysis, treatment is so much more effective than source country control or border controls or policing and that kind of thing. And the Congressman, John Micah at the time, turned purple. I mean, he just turned purple, and he said that, and he started shaking, and he just couldn't control himself. He said that law was propagated by the Clinton administration. He said, that report, no, he said that report was the most damaging report in the history of our nation because it allowed Bill Clinton to have drugs flow into this country unimpeded. And he kept saying unimpeded. And I said, well, the data were pretty clear at the time we wrote the report, and that was, of course, even before my term as director. I said, but it was very clear that treatment was much more effective. And he turned to me and he said, bullshit. I mean, this is in congressional hearing. So I thanked him for having read the report. And that was, what more can you say, right?
Yeah.
This is a very emotional issue between those who believe that you need to eternally punish people for deterrence and those who believe that this really is a public health issue and that we need to have options for care. And now it's becoming a financial issue, and that the options are increasingly financial, and we need to be keeping our eye on that because the abuses pile up on minority communities. But but it does provide room to talk about the huge expense of incarceration for our nation, especially with an aging population of individuals in prison now.
Martin, what is the cost in a year of a prison in California, let's say, for a person?
Well, it was 20-something thousand, but Bo, you have those numbers better than I do.
Yeah, I mean, I've seen numbers ranging anywhere between 30 to 60,000 a year. It depends. Yeah. It depends on kind of are they focusing on the marginal cost? Are they focusing on the average cost? I think Martin raises a really good point, especially for the aging population and their healthcare costs. They're going to tend to cost a lot more. So that's something to kind of keep in mind. That it's not, once you kind of break it down by the different characteristics of those who are incarcerated, you're going to get some different costs there.
And the cost for a treatment program for a year?
Oh.
On average?
Well, obviously it depends on, the type of treatment. So Washington State Institute of Public Policy, they do a lot of cost studies. I mean, and they look at like a cost of methadone or cost for buprenorphine, I think for a year was somewhere around $4,000. Now it depends also on, who's covering the cost. Is it insured but I mean, in general, the cost, of course there are really expensive treatments. They're in Malibu and places, but in general, treatment's going to be a heck of a lot cheaper than incarceration.
Great, thank you.
Well,
and treatment is short-term, right? I mean, well, not necessarily short-term if it's an opiate user, but treatments are episodic. They're not continuing forever like imprisonment does. So those costs go on and on and on, especially with 3 strikes. And that's not the case for treatment. Treatment benefits accrue. They become, individuals who recover are taxpayers. They build healthy communities. They become, citizens in their community that are contributing, as opposed again to incarceration. Sorry, I cut somebody off. I apologize.
Very interesting.
Well, hi, Martin. It was just me. I just wanted to make a point that I guess I feel oddly kind of reassured by this discussion, even though the challenges are so immense and the barriers. But I think this whole idea of the impact on communities within this public health discourse that is starting to, I think, become more broadly accepted. And I think the social justice movement and the effects of incarceration on communities, we're starting to see broader acceptance of that and intertwine with that the effects of the criminalization of drug use. And perhaps this might be a moment where we can really move forward this effort to re-examine our drug policies, to look at how they are not they are doing damage to our community health. I just think we're all having that discussion now in other areas, and it might help to bring it together. So I'm oddly optimistic after this discussion.
And I was just going to say, the one thing that's about decriminalization is that it's something a jurisdiction could try. You could do this for a few years, and if you decide after 3-4 years that, hey, that wasn't the right thing to do, it would be easy to change course or go back. I mean, it's a lot. That's a lot. Especially what's happening with cannabis legalization of for-profit companies. Once they get out there, they get their lobbyists. 10 years down the line, you decide, oh, I want to try something else. It's a lot harder to put that genie back in the bottle. But at least with decriminalization, this is something that jurisdictions, could try for a while, see how it goes. But then also, once again, the question's going to be, and I think this is something that Linda was getting at as well, was it just going to be decriminalization, or is it going to be decriminalization with a large infusion of funds for treatment and for outreach and for harm reduction? Because I do think that would make a difference there. But that said, even a jurisdiction that just decriminalized, it would and didn't necessarily have this infusion of resources. I do think it would be interesting to kind of look at that, just because there is this stigma issue in that would it lead to more people asking for help and seeking help? I don't know. I think one of the interesting things I think I might have talked about before is in Oregon, now that they're actually delaying when they're going to open up these addiction recovery centers. I think there's some really interesting variation there in terms of how this is being implemented and how it will be implemented in different parts of the state, where I think we can get a good sense of or get a better insight about what happens right when you decriminalize, but you don't necessarily have those funds for those other services. Is that beneficial at all?
Kind of a natural experiment, you're saying.
Yeah, just caused by just just in terms of administrative purposes. And so, I mean, granted, people can still make the phone calls for the referrals. But it looks like they probably won't. They may not have those centers open until maybe October of next year, potentially. I know they're debating that. So you're going to have this long period in there. That oversight council still has to decide how they're going to spend all this money. So you could imagine, that could take time. So you imagine you could potentially have a year here where they have decriminalized, and you really haven't seen this infusion of resources. What happens then? So I think that will be informative.
Yeah, the benefit of that is that given an action at the federal and world level, you have bottom-up policymaking, right? Communities show the way, and they collect data. You have comparisons. You have a more empirical approach to policymaking that eventually, like medical marijuana and really what's happening with marijuana in the country, begins to persuade even people like John Bonnert, who's now on the board of one of these marijuana companies, right? So I think that there's a huge benefit to those kinds of experiments, natural experiments, and to really allowing states to flex their muscles and in trying different approaches. This is a lot like, I actually addressed this about 15 years ago in Prague, and I talked about how drug use and drug laws actually were the classic example of how communities can take control of what's happening and to really begin to make change and collect data that's relevant to how they'd like to see, the changes made.
I think the one thing I would kind of on the flip side of that, though, I mean, we do see it with the discussions about supervised consumption sites, and that the feds really have, have been, the U.S. Department of Justice has been blocking these efforts, and so it'll be really, and which is so frustrating because, I mean, there's so much we need to learn about supervised consumption. I mean, there are 150 of them operating throughout the world, but a lot of that research was done kind of pre-fentanyl and or pre-illicitly produced fentanyl. So there's a lot we have to learn about them. And so this would be the time when it'd be great to start researching that. But if we don't have them operating, that's quite hard. And so it's gonna be interesting to see what the feds do. I mean, obviously they could change the Controlled Substances Act. But then, what else? They could also just do what they did with cannabis. After Washington and Colorado legalized, they essentially put out that memo saying, look, this is still illegal. It's not going to be a priority for us. And then it'll be really interesting to kind of see how the new administration deals with this. Because there are a lot of communities, in San Francisco and Philadelphia and other places that really just want to give this a shot. And so, so I would say, so I'm in agreement with you, Martin, but there still are some things to where the feds are making it quite difficult for the local communities to experiment.
Yeah. You have to have patience, right?
Yeah.
It doesn't happen. All these things don't happen overnight. And frankly, supervised consumption sites are a step too far for many communities at this point.
Right. Mm-hmm.
And the lack of data, as you point out, is a catch-22. That there's not enough support from data. There's not enough support from communities because there's no data. But also because there are options they still haven't implemented that are halfway there, right? Many communities still ban needle exchanges. That seems absurd to me. And I think that there's yet still so much to do in terms of just changing the narrative in so many places that these are not bad people who deserve punishment. These are really just people, and that they deserve to be treated with dignity, respect, and to have access to treatment. And the more you pass that message along, the more you actually implement that message, the more effective treatment becomes because of the destigmatization and the willingness then for people to follow through and to be there. For many, many years, treatment was abusive, right? And it tore people down rather than building people up. And I think that we're moving away from a lot of that as well. So there's so many ways in which we need to make progress that, I see your point, but look how long it took for marijuana to even be, before NIDA, for example, would even acknowledge that it was a problem that they should research.
Mm-hmm.
And currently we're working with FDA through CPDD, the College on Problems of Drug Dependence, and NIDA to change scheduling of like drugs so that more research can occur in more controlled settings to at least set the stage for expanded, research in communities so that we know more about the characteristics of these drugs. I mean, new drugs are showing up all the time. So we still need to really understand all of these things are coming onto the market. And, so these are, again, incremental steps.
Okay, why don't we wrap it up with that? It was a really great panel. I learned a lot, enjoyed it very much. Hope our participants enjoyed it. And we thank very much our panelists today. And maybe we'll do something like this in a couple months again and to keep on the dialogue. Thanks, everybody.
Thank you.
Thanks. Bye-bye.
Thanks all.
Thank you all.
A pleasure listening to the other speakers.
Yeah, it's great.
Great.
Yeah, it was a treat. Thank you all. Bye.